As a dentist, we prepare indirect restoration on our day-to-day dental practice. And it would be nice to have some list of things we need to do before we start preparing those crowns or veneers or onlays. In this video, I'm going to discuss about 9 main things which I feel we need to consider before doing any indirect restorations. Step number 1 is doing clinical assessment. When we are doing clinical assessment, you're assessing restorability of the tooth, you're assessing endodontic status, periodontic status, and alignment of the tooth, whether the tooth is in the right alignment. Do you have to prepare a lot of tooth in order to do your indirect restoration? If that's the case, we know that, in 90s and 80s, many times we prepare the teeth for veneers which were not straight because orthodontics wasn't very popular and wasn't very easily accessible. Nowadays, if patient comes to me with anterior crowding, upper anterior crowding, wanting nice straight teeth, I'm not going to jump into veneers. I would do orthodontic treatment and do nice alignment, possibly just bonding and whitening, and that will do. However, you need to make sure that you assess the alignment of the teeth before you dive into indirect restoration. Now, let's look at some of the examples. So let's say patient comes to you with this tooth. It's very easy to understand that, okay, probably it's restorable. There is some tooth remaining and you can restore that tooth. If that tooth comes out, you need to probably tell patient that, I need to remove this old restoration, assess how much tooth is left before I can tell you whether I can restore this tooth or not. If this comes to you in your clinical practice, then, the prognosis, whatever you do, post and core restoration or whatever you do, it will be guarded. So you need to have that discussion with patient that, look, you will end up spending a lot of money on endo, possibly post and core crown with still guarded prognosis because more than half of the tooth doesn't have any ferrule. And we know we want ferrule when we're doing post and core restoration. I will cover that in future videos about post and core. But this is going into guarded prognosis, and you need to really have a discussion with patient that, about the cost involved, whether it's cost effective to take the tooth out and place an implant. Now, I placed over 1,500 implants and I do routinely very complex implant surgery. However, even I tell my patient that, look, implants not for a lifetime, and many patients will get surprised that why it's not for a lifetime. So, although it may sound easy to just take the tooth out and place an implant, I would do everything I can to try and keep the tooth. But at the same time, you need to understand with patient's budget. If patient's spending a lot of money, you need to have that clear conversation with patient that, this may not last, and you need to let them know. Otherwise, they might not be happy. They're spending a lot of money and the tooth might have to come out later on. Now, if this tooth comes to you in your clinical practice, then you know that whatever you do, the tooth really needs to come out. So again, that kind of frank conversation you need to have with your patient that this tooth had enough and we need to take it out, unless you really want to throw everything at it and patient is willing to spend all the money on that tooth without expecting any result. So make sure that you have that discussion with patient, assess the restorability, and assess all the perio, endo, and alignment status of the tooth as well. Point number 2 is you need to take radiograph for any indirect restoration you make. I practice in UK, and we have indemnity, obviously, as any country have indemnity insurances, and one of the criteria is you need to have post-operative PA, periapical radiograph, before you do any indirect restoration to make sure that there is no periapical lesion. And this is the kind of scenario where you take this periapical radiograph and you see that there is a PDL widening. Also, the caries is almost equicrestal at the bone level. So you need to have that conversation with patient. Many times, my mentees come to me and say, look, the tooth is restorable. Endo is questionable, i.e. you will have endo which is half-filled root. Patient never had a problem. It's been 20 years and patient doesn't have a problem. Now, very well within the reason, patient will say, why do you want me to do re-endo? This tooth has been no pain, it's just broken. I just want you to fix it. You need to explain it to patient that, when you start removing old restoration, you are changing the environment of the tooth, and there is a highly likely that that tooth might flare up and might get painful or may need root canal treatment. And once you've done the crown, it might be not ideal to drill through that crown and do the root canal treatment, the new precious crown. So that's conversation you need to have with the patient, and then discuss with patient and decide along with the patient whether you feel comfortable treating that tooth if patient says they don't want root canal treatment. However, it's very important conversation you need to have before you do that. when you do periapical radiograph, make sure you do vitality test as well, because again, for your notes, it's very important to check vitality and record in your notes, because we know that 1 out of 4 or 1 out of 5 indirect restoration, when you prepare the tooth for the crown, they do become non-vital. So you need to assess the periodontal or initial endodontic status of the tooth before you do any of the indirect restoration. Number 3 is related to aesthetic anterior restorations. You need to assess patient's smile line. Now, there are 3 different smile lines. You have a patient like this where patients come to you and they smile really wide, but only showing 2-3 millimeters of the incisal edge. Now, these are dream patients. You can do whatever you like and you can probably get away with it, unless those patients are, habit of pulling their lip up and say, oh, this marge is not good. You can get that kind of patient. So make sure that you let the patient know beforehand that if you're not planning to correct the gingival zenith margins, because it could be up and down, but you might get away with it. So, but have a chat with the patient. Just because patient has a low lip line, don't underestimate that, the patient may not have higher expectation. This is sort of a medium smile line where, not all the teeth are fully visible. However, if you're doing lateral incisor, it might be a little bit different than the central incisor, but still I would say it's pushing towards high lip line. And of course, if patients like this come to you and you're changing those central crowns, then you have to be very careful and you need to plan this meticulously. It looks like there is caries and you need to possibly do crown lengthening because you don't want to encroach into biological width. But again, you need to assess this along with radiograph and discuss with patient the aesthetic implications of your treatment. Number 4 is shade taking. Yes, it comes before you start preparing your tooth, because we know that when you start preparing the tooth, when patient has kept the mouth open for too long, teeth change color. So make sure you take the shade before you start preparing of the tooth. For shade taking, I generally tend to take photos like this. If I'm not sure, I'll take a couple of shades so then technician can kind of compare what the A3.5 looks like rather than A3. And even if I'm sure like it's the A3, I would still tell technician that it's A3, but have 2 shade taps next to each other so they can kind of compare the shades. Now here you can see that the patient had an implant crown fitted on upper right too, but the crown looked quite white. You can see patients got different color. So I took again shade tabs out and then sent it to patient because it was very difficult to match the shade with any shade tab. And here patients got multicolored tooth. Now which color we should match to, and this is something you need to involve patient with. Which tooth patient won't like us to match the restoration? In this case, patient wanted to match the restoration with the lower because he was having this implant crown changed as well. So we tried to match it with the lower incisor. Patient didn't want any whitening. So this is the shade we went for. But again, you need to involve patient in shade taking exercise as well. Number 5 is diagnostic wax up. Now this is an amazing tool when you or your patient don't have an exact idea as to how the final result will look like. If patient comes to you with exactly the nice shaped tooth and just wants to change the crown but like the same shape, then it's fine. However, if patient wants to change the shape of the tooth, then it's really important that you try that out before you start any procedure. And one of the ways to do that is to do diagnostic wax up. So this patient came to me to correct midline diastema. And what we did was a diagnostic wax up, had the 3D printed model. We then tried that in patient's mouth. Patient was happy with that. And then we converted that using direct composite restoration and closed the diastema. But patient wasn't sure before that. Patient thought that her teeth will look bigger if we close the midline diastema. And that's why it was important to show patient how it will look, because even this might look big for some patients. So it's very important because it's subjective. So make sure you assess, do diagnostic mock-up before you do any final restoration. Hey, my name is Dr. Devang Patel and I've been teaching for nearly 15 years. I've taught hundreds of dentists full mouth reconstruction, and I have a treatment planning club where I teach treatment planning. If you're interested in receiving free email regarding treatment planning, then click on the link in the description and I will send you 8 emails considering treatment planning in general dental practice. So let's go back to the video. Number 6 is material selection. Now this is really important. Again, we haven't yet gone to preparing the tooth. You need to do all these steps before you even take a fast handpiece and start drilling the tooth. You need to assess first what kind of material are you going to use. Are you going to use any type of metal like a gold or non-precious material like this here? I'm planning to do 6 gold onlays for this patient. Or are you planning to do zirconia crown like this patient, where I've done 3 to 3 zirconia bridge because patient couldn't have implant. Unfortunately, he was going through cancer treatment and his cancer team didn't recommend any surgical intervention. So we did 3 to 3 zirconia bridge. Or you are going to use any sort of Emax, which is lithium disilicate, or feldspathic porcelain. Now here, this is an onlay again of Emax, which is very popular material for posterior restoration. Also for veneers, if you're doing anterior veneers, you might want to use Emax. Feldspathic veneers are really lifelike veneers. They have much nicer aesthetics. However, they can be very fragile, so you need to handle that with care. My go-to material is Emax, again for the veneers as well, because it's easy to handle. However, if I'm doing very thin veneers and patient wants really lifelike sort of result, then I would do feldspathic porcelain. But this will really matter how you're going to prepare your teeth for your indirect restoration. Now, point number 7 is design. Finally, we come to design, where we are now designing the veneer prep, crown prep, or onlay prep. Now, by this time, we know exactly what type of preparation we are going to do, because we know the tooth shade, so we know how much masking we will have to do. We know what material we are going to use, so we know that if you're going to use gold, we can get away with 0.7 to 0.8 buccally, and then you can get away with 1.2 millimeter to 1.5 occlusally, depending on the functional cusp or non-functional cusp. However, if you're doing Emax onlay, then you want that 1.2 millimeter thickness everywhere. So again, if you're doing zirconia, you can do verti-prep and you can really thin it down, your zirconia crown. So again, it depends on the material, what material you're going to use, the design. But you've already worked out by now what kind of design you're going to do for your indirect restoration. Number 8 is provisionals. What kind of provisionals are you going to provide your patient with? Are you going to use something like clip or telio, which is temporary composite material for your posterior onlays to stabilize just the occlusion and cover the preparation? Or in this case, where I've prepared 10 veneers, or spot etch the area and give patient a provisional veneers, shrink fitted veneers. So are you going to do that for your crowns? Are you going to connect all of them together, or are you going to do 2 at a time? This is all you need to make a decision when you are provisionalizing. Make sure that you work this out before you start any preparation. And lastly, number 9, you need to consider, are you going to cement your restoration, or are you going to bond your restoration? And this again depends on your preparation as well. If you have preparation like this, where you got nice enamel, very minimal preparation, then you can bond this. And as you can probably guess, that this was prepped for veneer. However, if you are redoing the old case where someone else done the crown, and you remove everything and you see this kind of teeth where completely everywhere there is dentine, the success rate of bonding will be questionable. Although we can bond, I would be thinking more about cementing my restoration, doing crown, possibly zirconia crowns, to cement those zirconia crowns, because bonding to these, again, is not impossible. I've done it before, but if I can get away with the crown, then I would probably consider a crown. So these are the 9 points you need to consider when it comes to doing indirect restorations. I hope you enjoyed this video. If you have, then please make sure you subscribe the channel so I can forward you more and more these type of video in the future. And I'll see you in future.